second Small Counties Fiscal TA webinar with Mike Geiss. We'll get started in just a minute. Just a couple of things. As always, you are muted at this point, but you can ask questions by typing in your question in the question box or by raising your hand, clicking on the hand next to your name. We'll have a couple of announcements at the end about future trainings and webinars. So I sent out the materials this morning. If you didn't get the materials, send me an email. And without further ado, let's have Mike start.
All right, good afternoon. What we're going to do today is cover what was discussed at the October 3rd Financial Services Committee meeting. And you can see the list of agenda items there on the screen. And starting off with the new billing feasibility system study, again, as we reported out last time, CMHDA is funding this feasibility system or feasibility study for a new system, for a new reimbursement system for Medi-Cal, especially mental health services. Cal MHSA is managing the process, and you can see the staff from Cal MHSA, the person Sarah Brickler. That's her email address if you have any questions or need any information on the process or the feasibility study. And what they're responsible for is invoicing the counties for the share of funding that is the responsibility of each county. Again, we went through that last time, and there was a schedule. Since then, they have also, Sarah sent out an email to counties asking basically to determine the level of participation and knowledge about the study from the counties. So you were asked to respond, yes, you intend to participate, no, you don't, or whether you wanted additional information. And if you didn't see that email, there's a copy of it on the CMHDA Financial Services Committee handouts page, and you could probably just respond from that point as well. They're also going to assist with the procurement, in terms of developing scope of work and then actually putting together a procurement document and soliciting proposals and those sort of things. And then finally, they began hosting these calls for counties that had questions. And the first call was a couple weeks ago, October 7th. And I'm not sure if there are any more calls scheduled at this point, but again, Sarah would be the person to contact if you have questions. Also, as part of this, there's a governance committee that has been formed, and they're going through 3 very focused meetings. They already had their first meeting October 8th, which was a presentation by DHCS on kind of how they arrived at this point and saying that they need to do a feasibility study for a new system. The next meeting will be primarily, I believe, CMHDA doing the presentation, both myself and Thad, talking about some of the issues and background, and then also getting into some of the federal requirements around both the IT claims sort of system issues or requirements, and then I'll get into the reimbursement requirements from a federal perspective. And then the last focus meeting is to try to develop some consensus on the focus of the feasibility study report. It was reported out that both CSI and the DCR system are not in the scope of this feasibility study at this point. But I think everybody is aware that it's pretty much no longer just an IT project in terms of looking at just a billing system versus looking at potentially a different reimbursement approach, which would have different fiscal policies associated with it rather than this adjudicating claims at the state level on a minute of service basis. There also then will be formed a steering committee, which will have representatives from the CMHDA committees as well as DHCS. And in terms of the timeline, it's somewhat slow to go through the whole procurement process, but they anticipate a vendor selection by March 2014, so next March. And then the actual study itself would be conducted from March through December of next year. And really, you know, in terms of committing funding on an individual county basis, it's really not until kind of that March timeframe that counties will actually probably have to write checks to Cal Mesa if they're going to participate. But at that point, they would need the funding. So that's a feasibility system study. We're actually, I think, going to talk a little bit more about some of these options in the CIMH Fiscal Institute that is coming up next month on, I believe, November 5th and 6th. Are there any questions on the feasibility system study? All right, moving right into Short-Doyle 2. So again, we've been talking about this for a while, the other health coverage denials for the Medicare risk HMOs. So where we are now is that DHCS is developing an information notice that will just basically tell you how to go about getting approval to go ahead and submit claims that would be denied, but you can by submitting a letter to DHCS that includes a letter from the Medicare risk HMO saying that they do not cover those services. The state would put, I guess, an edit in the system to allow you to go ahead and bill for those services directly to Medi-Cal rather than having to get them denied by the Medicare HMO and then bill Medi-Cal. And so again, you'll need a letter from the Medicare risk HMO to the county mental health plan stating the service is not covered. And then you would have to send that on to DHCS. The one downside that we heard is that rather than requiring one letter from each Medicare risk HMO that could cover multiple counties, it sounds like every county that has a client in a Medicare risk HMO needs a letter from that Medicare risk HMO. So we had hoped that just one letter would cover all counties, but it sounds like each individual county would have to submit letters for every client or for every Medicare risk HMO that they have clients with. Once you get that letter off to the state, then you can go ahead and rebill for those services. And I guess they'll tell you how to do that. We talked a little bit about the production testing. I think the main thing that we found out, and hopefully you all know this, that the live test data is allowed just through the end of this month, basically, and that there'll be a new test environment after that date. The state had already posted some trading partner instructions on ITWS, which we went ahead and sent out as part of this this call today. It kind of goes through the plan change, and then it goes into some of the technical things on how to work with your training partner and get this thing set up after November 1st. So just so that you're aware of it, that the test environment will go away or will change on November 1st. We talked a little bit, and the other part of this too is that apparently DHCS will issue an information notice, probably with similar detail as to what's in that that trading partner instructions. And moving on to KDA implementation, DHCS did present a report, and this report is posted on the CMHDA Financial Services Committee handouts webpage. We didn't really send it out because it sounded like a lot of the data wasn't necessarily correct. It showed that only 9 counties had reported KDA services. And in fact, 94% of the dollars all came from one county, and that was Orange County. So it wasn't really telling in terms of what's going on, at least hopefully with KDA. And then further, we discussed that that the Los Angeles County data was not accurate, and that they needed to do some changes to the reports to be able to accurately reflect the data. So, but at least now it is being collected and being reported out. And then we also talked about, in terms of reports, there was a Healthy Families Transition to Medi-Cal report. Again, this is also on the CMHDA Financial Services Committee handouts webpage. It doesn't show a county-by-county report at all in terms of the number of clients that have transitioned over. So it isn't, I don't think, really that beneficial, but at least there is a report if you want to see how the Healthy Families transition to Medi-Cal has gone. And then finally, they talked a little bit about their claims payment timeliness report. And this report is posted on their MedCC library website. And it just shows how long it takes them on a monthly basis to pay approved claims. And it showed that it spiked up, that the amount of time it took almost doubled from around 30 days to more like 50 to 60 days towards the end of the fiscal year. Their goal their stated goal, at least for the past, probably the past 3 years, I think they've been saying that they're trying to get down to where they pay within 30 days. And so this kind of tracks whether they're achieving that goal. The one thing that they did mention is that they are still only receiving warrant files from the state controller's office, warrant numbers that have to get posted into the 835 files. They only get those once a month at this point, and that beginning in early 2014, they're hoping that that will change and they can get those reports or those files more frequently from the state controller's office, which will allow them to post the 835s more quickly and potentially pay a lot quicker as well. And then we talked about the CMHDA IT Committee SWOT issues and some of the things they're dealing with, one of which is this transition to the DSM-5 or implementation of the DSM-5. Apparently DHCS is working on an information notice that will provide you counties guidance on that. There won't be an immediate switch to this DSM-5, but what the SWOT team has recommended is that the DSM-5 be implemented at the same time as the switch over to ICD-10, which is next October, so a year from now. And apparently this delay caused some sort of problems with Short-Doyle 2. Many of you might have received emails from DHCS Short-Doyle system saying don't submit claims with dates of service after October 1st, 2013 until after 5 o'clock today. And so there must have been some issue that they're having to put a patch on to address the change moving to October 2014. And then finally, one of the things SWOT's working on are the CPT code changes, and again, waiting for more guidance from DHCS to provide the crosswalk basically between the CPT and the HCPC codes that are used in the Short-Doyle 2 claims processing system. Does anybody have any questions on any of that, that information? All right, and then
Mike, there is a hand raised. Just a second.
Muted.
Kathy Denton, did you have a question? You're unmuted.
Actually, I was going to write that his mic, your voice keeps on fading out, and I just don't know if it's me or not, but every so often there's no sound.
Okay. I will try to keep the phone up. I might be putting it down when I'm looking at some of the material. But hopefully
it could be my system.
Okay.
Because you're on your computer instead of your phone.
Oh, okay.
If you want to try to transfer to the phone, that might help. But we'll go on.
And I was going to type it, and for some reason, I guess my hand was still up. I'm sorry.
And I'm getting reports from the field that other people can hear, and they're having no problem. So
okay.
Must be on your end. Thanks, everyone.
Okay. And then the last thing under the Short-Doyle 2 update were these county contract rates. And we talked about these last time. And this is where DHCS wants to put what they call a backstop into the Short-Doyle 2 system in case there are data entry errors on the county's end, so that they don't, overpay a claim. And so what they've had suggested is using a rate that is twice the highest county interim rate as kind of this backstop for each of the different service function codes. What they were going to initially do, or what they had suggested, was to go ahead and adjudicate the claim at this high rate. What the county suggested a month ago was, or a month and a half ago now, was to, rather than adjudicate the claim at that rate, to just suspend the claim and call the county. The state said that they cannot do that. They can't really suspend the claim, and I think part of this is because they're trying to use the same edit that they put in place for counties that tell them what the contract rates maximums are for each provider. So I think they're trying to tie the edits together. And so they said they couldn't do that. And so then the county suggested that rather than suspending the claim, just go ahead and deny it, because to pay it at some rate that you're not familiar with or not aware of would make it incredibly difficult to reconcile at a later date. And so it would actually be better just to deny it, and then you'd know it was denied, and you could figure out and resubmit the claim at the appropriate rate. And again, this is what's interesting to me about this is this has never occurred. There has never been a situation where the county basically put their rates into your rate tables incorrectly to the point where you significantly overbilled, but for some reason DHCS feels this needs to be in the system. So we'll see, again, what the state comes back with, and to whether they are willing to just go ahead and flat out deny the claims rather than adjudicating them at some rate that you're not aware of. Anybody have any questions on that?
There is a question. When will the crosswalk report be ready?
So I assume you're referring to the CPT codes, and we didn't really get a timeline, I don't believe, in terms of when this would be completed. So this again is something that has been around for a while. Although it did sound like they were making some progress on it, but again, it's going through the SWAT team on the CMHDA IT committee, and so hopefully maybe by the end of the year, this calendar year, we'll see something. But I don't believe there was a specific date discussed at the meeting. All right, moving on to the claims payment update, and we talked quite a bit about the behavioral health sub-account, and really there's at least two issues here. One had to do with there is some growth in 1213 that of funding that needs to be distributed, and so what initially occurred was that the relevant associations, which is CMHDA, CADPAC, and CSAC, developed a set of recommendations that they provided to DHCS, and we covered those last time. DHCS subsequently conducted a stakeholder meeting at the end of September, and if you want to see the presentation, although I didn't find it really that beneficial, you can look at it. It's on CMHDA's Financial Services Committee handouts website. But I think what is important is that there is $27.8 million of actual growth in 12-13. The state indicated they anticipate distributing that this December. They also provided some estimated growth for 13-14 and 14-15, and you can see that growth does start to increase quite a bit as the $200 million pay basically restoration to the child welfare system after that's met. The percentage of growth that comes to the behavioral health subaccount increases pretty significantly. So in 2 to 3 years, we'll start to see some pretty good growth. So we don't know at this point how the $27.8 million is going to be distributed, and we're actually not going to wait and see. We're doing that survey, which I'll talk about at the end of this this discussion. But the one thing you need to understand about the growth is that the behavioral health subaccount growth works just like growth in the 1991 account. For those of you that were around when we actually did receive growth back in the early 2000s, late 1990s, in that the growth isn't known until you're already into the next fiscal year. So generally, you're not going to budget for growth in the fiscal year in which the money's earned. So you'll get the check for the growth for the prior fiscal year while you're already into the next fiscal year. And then in addition, the base then goes up for that year that you're in, because the base is equal to what the prior year distribution amount is. So it's kind of a little bit of a windfall in that you're getting the growth check for the prior year, plus then you have an increase in the base. The one downside with this behavioral health subaccount is what we're going to cover next, is that the state actually changed the percentages for 13-14 fairly significantly in some cases, so that what you received, even with the growth for 12-13, may exceed what you're going to get in 13-14. So if you look at the distribution schedule, this is the Department of Finance letter that we distributed. You'll see the total percentages for the behavioral health subaccount by county. And this is total. I know what's interesting, if you look at the very top of this thing, it says substance abuse subaccount allocations, which isn't correct. So I think a lot of folks interpreted that to mean, well, that's just the the alcohol and drug program allocations. That's not the case. This is the entire behavioral health subaccount allocation. And so these are the percentages, at least initially, that they're going to use to allocate funds. And in fact, they did in September. The difference between these percentages and what was used to distribute the 12-13 funding supposedly only related to EPSDT. And the changes when you guys all certified your public expenditures for the final distribution for EPSDT for the 11-12, those percentages were different than the estimates that were used initially, and so the state somehow made some changes and came out with these percentages. The state has said that they will issue an information notice similar to Information Notice 1208 that shows how they came up with these percentages. So it'll be interesting to see. Because the other thing that they mentioned in their presentation for the stakeholders is that they updated based on EPSDT, but then they also updated based on KDA and Healthy Families transition data. So I didn't quite understand how they would be able to take that into account in these percentages. So we're all waiting for this new information notice, especially those of you who are trying to apportion that one check into your different programs based on whatever the state's saying is how they determined your percentage. So hopefully that will come out soon. It doesn't make a lot of sense why it hasn't come out, because it should have been fairly straightforward, but in any case, it hasn't come out yet. So in terms of the amount of funding that I think you can look at for 1314 in your behavioral health subaccount, you can take these percentages that you see here that might be revised. The state did say they may revise them, but at this point, this is what we have. And what you want to do is multiply that by what the new base is for the behavioral health subaccount. And that new base is the 987.2 million total 1314 behavioral health subaccount funding. And the way you get to that is it's the 959.4 million that was the 1213 base plus the 27.8 million 1213 growth gets us our new base of 987.2 million. So again, take this 987.2, look at your percentage on this thing, multiply it out, and that is, at least at this point, what I would expect you to receive in the behavioral health subaccount for 1314. This does not include, there's about 5.1 million that was carved out for a handful of counties for an ADP residential program. These percentages do not include that, nor does the 987.2 total million in total funding. And then also there is anticipated, and there will be some growth in all likelihood in 1314. But again, that won't be known until a year from now. So to try to budget that in the current year, I think would be very difficult. And to try to accrue a number at the end of this fiscal year for that growth would be very difficult. So I'm guessing we've got some questions on this.
There's one question: how is the annual statewide growth amount calculated?
So it varies by fiscal year. So it's based. So this is all sales tax revenue, and once a certain threshold, and there's roughly about 200 million that has to go to cover child welfare to restore some of the cuts they experienced pre-2011 realignment. But we start off at a very small percentage of that growth, the behavioral health subaccount. But once that 200 million has been restored, then I think we're up around 50% of the total growth that is received in the, I think it's called the support services account, which is basically all the behavioral health plus the social services stuff. There's also the whole jails and public safety side that also gets some of the growth in the sales tax, but it's all in statute. How it's actually then distributed by county is what we don't know yet. But the overall amount is in statute. The state can't mess with that. But and it's predicated on the actual growth in sales tax. And so we're hoping that in 1314 that most of that 200, if not all of it, has been restored to child welfare. And so that's why that 246.1 million that you see in 1415 growth, I think, does reflect roughly 50% of the overall growth that is anticipated. So until we get all that paid out, it's really tough to kind of model and figure out that once that gets paid back, then we will start to see, as long as there is growth in sales tax, we will see, growth every year of, hopefully a couple $100 million. All right. Any other questions? Okay. Moving on to some of the settlements, the cost report settlements. We talked a little bit about 910 that DHCS has sent out the reconciliation letters, and that as they receive the reconciled cost reports, they're settling them. And then they also again brought up that there are issues trying to understand the settlement for 8-9, and that, or actually it's not so much the settlement, I think, as much as some of the offsets that you're seeing against claims, and trying to reconcile that back to the actual settlement. And they're aware that you can't really do that, and hopefully they work on that, because I would imagine there's a bunch of tickets within the Med-CCC asking for information on how to reconcile it. And then we talked a little bit about the 1213 cost report, and how to report the Healthy Families clients as they transitioned into Medi-Cal. And really, and this is true whether it was the Healthy Families clients as they transition to Medi-Cal, or on the new eligibles, or anything, you need to look at the aid code in the month of eligibility, in which, or basically when the services were provided, what was the aid code that was used, or what did the client qualify under, and that aid code drives then what kind of units of service those represent. So as a client in 1 month they're in Healthy Families, that's one aid code. The next month transition to Medi-Cal, it's a different aid code. And those aid codes, once they transitioned into Medi-Cal, those fall under the enhanced children in terms of how you report them on the Medi-Cal cost report, because they're reimbursed at the 65% FFP. And then, again, we're still having issues around how what we call the green sheeting process, or the warrant offset process. And it sounds like at least the program staff within DHCS are meeting with the accounting staff to try to work out some solutions to make it much more transparent to counties, and make much more information available to you, so that you can reconcile these offsets to the correct funding source and fiscal year and everything else. Anybody have any questions on any of that? All right, then we talked a little bit about the systems analysis and integration. And apparently DHCS has been focusing more on not just the submission of CSI and DCR data, but also on the quality of data being submitted by counties, because they want timely and accurate data so that they can report out to various stakeholders what's going on in the community mental health system. So apparently they've been contacting counties more aggressively to say, where is your data? And the one thing that we've always asked for from the county side is, that's fine, we'll get you the data, but we want some reports out in terms of what does this look like, and how do our services look, and so give us some sort of feedback so that we can tell whether the data we're providing is accurate, as well as how the county looks. So hopefully more will come on that. DHCS did indicate that they've hired some new folks for this research section that will be dealing with some of this. And I'm guessing part of this too probably came out of that report by the Bureau of State Audits that was very critical of the state for lack of oversight on the MHSA program. There was a question around whether counties can submit the XLM files, and this is way beyond anything I am familiar with, so I'm just going to say that apparently the OAC was saying you couldn't. but DHCS says you can, and so if you have a certification request, you should direct that to MedCCC. And DHCS did say that MedCCC is also going to be involved in the CSI status and sort of in communicating that with the counties. And so we talked a little bit about MedCCC and what you should expect. I'm guessing a lot of you have contacted MedCCC over the years. You're supposed to get a response within 24 hours. In cases in which the analyst or person can't answer the question or issue right away, it can get escalated within DHCS, and it may take a little bit longer, which I'm guessing a lot of the issues do. We talked a little bit about that there are probably better ways to look at, at least the MHSA outcomes and performance, and not necessarily the Exhibit 6, which may be redundant. But LA has been doing some things where they've been able to track and monitor performance and outcomes. And then again, as part of this, any sort of performance and outcomes monitoring process, we would want to make sure there was some sort of continuous quality improvement built into the process. So you go through, you collect the data, you report the data, you submit the data, but then you're also getting feedback on the data to kind of complete the loop, so that if there are issues in terms of the quality, you can get those addressed, rather than what it seems right now is that you collect and report and then you don't hear out or hear back in terms of what you submitted. All right, any questions on that stuff? We talked a little bit about the revenue and expenditure report. And again, so you've got information notice 13-17 that has the report itself. You need to note that they did revise the form since it was initially issued, and they took out that innovation calculation, reversion calculation page. However, the new form still doesn't reflect the correct calculation of innovation reversion. At least it's not even consistent with their own information notices. There's still this whole disagreement on the interpretation of whether counties can dedicate funds to the prudent reserve that are PEI after 0708, so funds from 0708. So there's at least several county councils that are supposed to talk to the DHCS legal, and so they can hopefully get that resolved soon. At this point, I don't know what to tell you in the interim till that gets resolved, because the state is saying you can't report it. It was brought up that that the form does not allow you to make changes or to report changes made to prior year revenue and expenditure reports. So, maybe when you did the 1011, you thought expenditures, or actually it's probably more, you thought the offsetting revenues were one thing, but then, now here we are a year and a half, 2 years later, and it's actually a different number. There is no way to reflect that on the revenue and expenditure report. And what DHCS suggested is that you should send in the adjustments on a separate worksheet. But I think once they started to hear how widespread and how far back this may go, I'm not sure if they're still sticking to that or not. And then the other part is that if you do have questions or comments, you should direct those to DHCS, and I put on a URIS number and email here, because I think the more that they hear the problems that there are with this, with what they're trying to do, that either they'll, hopefully make changes to the report. But at this point, I forget when it's due. I want to say it's due like maybe a week from now or 2 weeks from now. but I doubt many of these issues will get resolved, and I'm going to talk about that a little bit more later. They also indicated they're in the process of developing an information notice on their reversion policies. And again, CMHDA has pointed out that you don't interpret, implement, and make specific statute through the information notice process. That is what the regulatory process is for, and the state hopefully will listen to that and try to go through, not try, but will go through the regulatory process to promulgate their reversion policies. And then it sounded like at the end of the meeting that DHCS may be creating a work group to look at the revenue and expenditure report. They are actually required as part of the statute to consult with CMHDA on the revenue and expenditure report. They really didn't for this one. So maybe they're realizing that they need to comply with statute and involve CMHDA. The downside is I have no idea what to tell you in terms of the current format, other than that's kind of what's out there, and probably to use it to the best that you can. All right, anybody have questions on MHSA?
Not questions, but a couple of people have written in to say that the revenue and expenditure report is due October 25th, next Friday.
Okay, thank you. Yeah, so not much time. So again, I'm guessing none of these issues are going to be resolved. And so when we get to the county-to-county part, I'll talk more about it. We had a real brief discussion on the workgroup updates, where DHCS is working through most of the issues with the fiscal SPA. Hopefully we'll see those supplemental claim forms soon. There's actually a call this Monday with the CMHDA work group to try to help the state respond to how counties, one of the questions from CMS was how do counties contract with the fee-for-service hospitals, and you know how you go about that process. So hopefully we can get that resolved. They're still working on the CP protocol, but hopefully that will be done by the end of this calendar year. And then the mental health cost report for 12/13, the detailed cost report template, and the instructions have been posted on ITWS. Again, there's been quite a few revisions, so I'd make sure you're working with the correct version. And they have said that they anticipate posting the summary cost report sometime this month. But as of about noon, it wasn't out. We talked a little bit about the Medi-Cal expansion update with DHCS there. You know, again, most of this is going to be, well, the way that the beneficiaries will be identified is through Medi-Cal aid code. There's going to be quite a few new aid codes, and so this is how the folks that are reimbursed at the 100% FFP will be identified as through their aid code. And so you carry that forward into the cost report, and you'll be reporting on those units separately than from the regular Medi-Cal units, and it will be identified by the aid code. There was a survey asking counties what their network provider rates were that CMHDA did on behalf of DHCS. And this is, DHCS is trying to establish the capitation rates for the health plans for the psychology, psychiatry, and group services that are the responsibility of the health plans and not the responsibility of the county mental health plan. So, and we had asked to see the results of that, and so hopefully we will see that soon. All right, any questions on that before I go into the county-to-county stuff? All right, so EPSDT settlement process for the AB 100. There's about $8 million that needs to go back and forth between counties. Some counties are owed, some counties owe other counties. But the problem we've got is that some of the data for the 0809 settlement, EPSDT settlement, was not correct for Riverside County, and so we're waiting to get that resolved before we put together any sort of process on that. Again, we talked about the behavioral health subaccount growth. in terms of how should CMHDA insert itself into the process. And so as a result of that discussion, which was quite lengthy, we went ahead and distributed a survey to you folks. It went out last Friday. And the main focus is looking at the growth in the three programs, which is the drug Medi-Cal, the EPSDT, and then overall specialty mental health Medi-Cal, looking at the growth from 11-12 to 12-13 to try to see if there is anything that we want to put forth as associations, as CMHDA and CADPAC put forth as a recommendation to the administration on how that $27.8 million should be split between the different counties. Again, that survey went out from Monica Scott last Friday. We're asking to respond by November 1st. You've been given flexibility in terms of how to develop the estimates, but really what you're trying to get to is what you think your final certified public expenditure for each of these programs will be for the 2 different fiscal years. This information will not be used externally until the Financial Services Committee has a chance to discuss it. Hopefully you can put something together and get that submitted by November 1st. We talked about the 11-12 MHSA revenue and expenditure report. And again, so we've got the ability to put PEI into the prudent reserve where we disagree with the state. And so Orange County, Los Angeles, Kern, and Riverside, I believe their county councils are going to take up the issue with the state and discuss, what the really 2 things where we're coming from, which is the statute says you're required to establish and maintain a prudent reserve that includes PEI, keyword being maintain, and how can you maintain a prudent reserve if you can never put money in, versus the state's perspective, which is that part of the statute says that in any 1 year you can only transfer 20% of the most recent 5-year allocations from CSS to either prudent reserve, WET, or capital facilities technology, and they're saying because that doesn't say PEI that you can't do it. So it's just kind of a different interpretation, and so we'll have to see what happens on that. So that isn't reflected in the revenue and expenditure report. The other part that's really a problem for some counties is the state's interpretation that FFP and all revenues, all offsetting revenues, as well as interest, need to be factored into the reversion calculation. So, they're basically netting that out to figure out your expenditures. And so, again, CMHDA's position is that this all needs to be done through regulation, not through a form. And so until that's done, they shouldn't be doing this. And there's a whole host of issues around this where, say you report offsetting revenues of one amount that turn out to be less, and they've already reverted the funds, the state would have no way to give you back the funds that they would then subsequently owe you. They don't have a settlement process in place for the revenue and expenditure report, and they don't have an appeal process. So there's just a whole host of problems with the revenue and expenditure report. What I've said is my recommendation is complete the form as best you can, go through and complete the unspent funds page, and if you're showing funds that revert and you don't believe it should show funds revert, then I wouldn't put anything on that unspent funds page, and just submit it at least with the component gross expenditures so that they can do some analysis and evaluation on that. I would then probably modify the certification and handwrite in something to the effect that the county does not agree with the state's interpretation of statute around the reversion policy, and therefore, in order to certify, could not complete that part of the form. So, given that it's only a week away, I don't think we're going to see any additional information come out from the state or from CMHDA on this, so that at this point is probably your best bet. Because to me, again, one of the critical things is you don't want to have your mental health director and your auditor controller certify to a reverted amount that you don't believe is correct, because I think that would give the state some leverage in terms of saying, well, you certified, so therefore we're gonna take it back. So anyway. We talked a little bit about the ACA implementation. CMHDA has been meeting with the health plans, and these are around the psychiatry, psychology, and group services covered by the health plan. The health plans, by January 1st, need to build out this network so that they can ensure these services are provided to their beneficiaries or to their covered members. In some cases, the county may be asked or to contract with the health plan to provide those services. And I think one of the critical things is to understand that these are not services that are county mental health plan services. And so therefore, they don't run through the Short-Doyle billing system, and they don't get reported on the cost report. So the costs or the units. Because they are the responsibility of the health plan, and they're not what we would call specialty mental health. And obviously more to come on this as we get closer and closer to January 1st. And then one thing that happened subsequent to the last meeting was that the general growth schedules for 12-13 realignment, the 1991 realignment, were distributed about a week ago, I think. But I think it's critical for you to understand that even though those schedules look like they're saying 40% of the growth is going to go to mental health, the reality is there's no 12-13 growth going to mental health because of the way that the CalWORKs MOE swap works. So remember when the CalWORKs MOE swap came about, we're guaranteed $1.12 billion for mental health in 1991 realignment. The CalWORKs MOE gets the funding that we would have gotten under 1991 realignment if we weren't guaranteed this $1.12 billion. And they will continue to get that funding, including the growth, until it equals the $1.12 billion. So in 12-13, the CalWORKs MOE base was about $986 million. The estimated growth that will go towards that CalWORKs MOE base or towards the CalWORKs MOE program is around 70 to 71 million. So that even with that growth from 12-13, the new CalWORKs MOE base for 13-14 is still about a little over $1 billion. It's $1.057 billion is what we're estimating. So we still need about 63 million more in growth to go to the CalWORKs MOE before we hit the 1.12 billion. And then after that point, we will see growth in the 1991 realignment. So we don't anticipate any growth from the 12-13 letter that just went out. We do anticipate that by the end of this fiscal year, there may be sufficient growth to fully meet the 1.12 billion, and that maybe we'll get a little bit, maybe 10 to 50 million growth in the 1991 realignment. But again, that wouldn't be known until October 2014, so it wouldn't be something you would budget at this point. So for 13-14, I would budget the same amount as you received in 12-13 for the 1991 realignment. So I know that letter was a little confusing, and it looked to show that counties were going to get growth in mental health, but really all that growth goes to the CalWORKs MOE until it hits the guaranteed amount that we're currently receiving. And then a couple things real quick on announcements. The November meeting for the Financial Services Committee was canceled because we've got, for you guys, the small counties, we've got the cost report training on that Monday, November 4th, from 1 to 5. And then on Tuesday and Wednesday is the CIMH Fiscal Institute here in town. And then, so Thursday we're not going to have a Financial Services Committee meeting. There will probably be a call at 10 a.m. to review the results of the survey, hopefully, depending on how many surveys we've received back, but there won't be a meeting. Because we're not having a Financial Services Committee meeting, we won't be having a small county fiscal call in November. But you're probably going to be inundated with cost reports and other stuff anyway. And again, so we've got the small county cost report training November 4th. And we really would like you guys to submit questions to Shoshana in advance if possible, so that we can try to tailor it specifically to any of the issues that you're facing or questions that you're having. That is it. Does anybody have any questions on any of the county-to-county stuff? I know that's quite a lot to absorb, but we'll be getting probably more into it in the Fiscal Institute, the first part of November as well. Talk more about some of these issues.
Has an invite gone out for the cost report training? Yes, it has. I can send it out again. But you can, well, actually, you can see it on our website on the conference page. The in-person part of the training is full, but we do have a go-to-meeting option that I can send to you.
Yeah, so there will be the go-to meeting similar to this for folks. Well, now I guess it's full, so for folks who will be on the phone. Then the other clarifying thing is we're just going to go through the mental health Medi-Cal cost report, not the ADP, and I don't want to get into the revenue and expenditure report. Although if we have time at the end, we can try to, I can answer questions at whatever questions you guys have, but the main focus is the mental health Medi-Cal cost report.
There's a question. Can you explain how ST growth affects 1991 realignment versus 2011? Is the 27.8 million growth for 91 only?
No, the 27.8 is purely for the behavioral health sub-account, which is the 2011 realignment. The growth that we anticipate for the 91 account that will all go to the CalWorks MOE swap is about 71 million. They're different percentages. They get different percentages of the sales tax. But they are, and actually the 91 realignment isn't just sales tax. It's also, there was an increase in vehicle license fee in 12-13. So it's a combination of looking at the overall growth, then also funding the caseload costs for social services, because there were some unfunded caseload costs, and after that, then the rest goes into a general growth, and mental health gets like 39% of that on the 1991 realignment. But again, that is still not sufficient to fully fund the CalWorks MOE at the amount that we're currently guaranteed, which is the 1.12 billion. And until the CalWorks MOE is funded at that level by receiving growth, we won't see any growth in the 1991 realignment. But if sales tax and VLF, they went up pretty good last year. If they go up, I think if they go up at least 5% this year over last year, then we'll see a little bit of growth in the 91 account in 13-14. So I don't know if that's explaining it, but it's pretty complicated. And again, for the 2011 behavioral health subaccount, once that $200 million gets paid to the child welfare, then we know we're getting half of that growth. And then once the $1.12 billion is reached on the 1991 account, then we know we're getting 40% of the general growth in that account. So.
Additional question, what was the mental health percentage share of the net growth? 49%?
No, so it's like 39 point something percent. That's why I just rounded it to 40% of the general growth on the 1991 account. The 2011 account, I don't know it off the top of my head. It's not real high. I want to say it's like 20%. Until that $200 million is repaid, something like that. And then after the $200 million is repaid, then it goes up to 50%.
That seems to be it.
Great. Then, sorry we ran a little bit over, but hopefully it was informative, and I look forward to seeing you guys in, I think it's a little over 2 weeks at the cost report training. Thanks.
Thanks, Mike,
Bye-bye.
and thanks, everyone. A recording of this webinar will be posted on our website sometime next week. Thanks.
Bye-bye.
Bye.